So, hello, good morning, good afternoon to everyone joining us from around the world. I am happy to welcome you to today's webinar. My name is Martin Mwangi. I am the program lead and senior technical advisor at the Micronutrient Forum. I lead the Healthy Mothers, Healthy Babies Consortium. It is my pleasure to serve as your moderator for today's webinar, and I'm joined by really experienced panel of speakers who I will be introducing in a moment. Our webinar today is titled Scaling Impact, Innovative Pathways for MMS in Full Multiple Micronutrient Supplementation in Maternal Health. I want to start by thanking dsm-firmenich for hosting this session in collaboration with the Healthy Mothers, Healthy Babies Consortium. And for those who do not know, the Healthy Mothers, Healthy Babies Consortium is a program of the Micronutrient Forum. The Micronutrient Forum is a central platform for evidence and advocacy to improve micronutrient health, especially in lower middle income countries. And it has a mission to promote alignment and collective actions on vitamins, minerals, and other nutrients across sectors by bridging nutrition science, policy programs, and responsible business practices for health and well-being. In that context, the Healthy Mothers, Healthy Babies is charged with a duty to focus on data-driven decision-making, convene diverse stakeholders, such as you will see in our panel today, including governments and country representatives, research, academia, knowledge institutions, non-governmental organizations, technical bodies, UN agencies, private sector, and funders to drive policy change and program implementation so that we can deliver impact for maternal and child health. Today, we bring together perspectives across market shaping, manufacturing, global MMS programming, innovative financing, and all these are essential for scaling UNIMAP multiple micronutrient supplementation around the world. So what is the baseline, or where do we start? The evidence so far is strong. I think we have had the global MMS tag, MMS Technical Advisory Group, and other stakeholders from academia especially work together to provide solid evidence showing that MMS works. On many fronts, it impacts birth outcomes better than iron and folic acid. MMS is safe. MMS is cost effective. And actually, most countries, from what we see in our work at the Healthy Mothers, Healthy Babies Consortium, are now considering transitioning from iron and folic acid to MMS. At present, we have over 46 countries at various stages of transitioning from IFA to MMS. So, but to do this, to scale, it requires a systems alignment. It requires a policy update. It requires financing. It requires predictable supply. And it also requires monitoring of progress and strong governance at national levels. So our focus today will be simple. We will want to try and answer the question, what will it take to help countries, especially in lower middle income countries, move from interest in MMS to implementation? And therefore, our objective today is to inspire and mobilize diverse set of partners, NGOs, government officials, private sector leaders, key opinion leaders, and all of them with the mission to accelerate the adoption and scale up of multiple micronutrient supplementation for maternal health, leveraging market-based and innovative financing models, and sharing regional progress and opportunities. But before we begin, we want to invite all the participants to respond to a quick poll on the question that is going to be put on your screen now. So I request our tech team to put the poll on the screen. I invite you to respond to the poll, and I will pause here so that you can focus on the poll question. that 2/3 of our audience has voted, and the last persons are voting. I will want to invite my panel of speakers to briefly introduce themselves, and it will help if you can just add a conflict of interest statement towards the end of your introduction. We will start with Lucy, and then we will go to Lauren, and then we'll go to Lady Mary in that order. So Lucy, the floor is yours.
Thanks a lot, Martin. So I'm Lucy Klarsfeld-Magra. I'm the managing director at Hystra. We were a strategy consultancy specialized in inclusive business, active in nutrition since 2014, and in maternal nutrition more specifically for the past 6 years now. I look forward to telling you more about some of the market tests we were able to run in Pakistan, and more generally the private sector side of scaling MMS. And I do not have a conflict of interest in participating in this webinar. Over to you, Lady Mary.
Thank you so much. My name is Mary Dina, and I'm the CEO and founder of the Mary Dina Foundation. It's an organization established since 2005, so we're 20 years this year. We're operating across mainly conflict regions, fragile areas, supporting women and children affected by war and terrorism, and also affected by the activities of non-state armed groups. In these fragile settings, we're preventing malnutrition in pregnant and breastfeeding women and also in babies, and connecting women to antenatal care, vaccinations, and a range of other implementation services. Thank you so much, and it's great to be here.
Yeah. Over to you, Lauren.
Yeah, hi, good day to everyone. I'm Lauren Lau from Philippine Nutri-Foods. I'm the general manager of Philippine Nutri-Foods. We are a manufacturing company in the Philippines since 1977, and we are actively participating in improving the public health nutrition in the country. I have no conflict of interest for this session. Thank you.
Thank you.
And
so
I have
much.
no conflict of interest for the session. Thank you.
I planned to say that on your behalf, but thanks for coming back to clarify that. So I want to thank you all for joining us this morning, and I know you are joining us at odd time zones for some of you. So I also appreciate that you taking time out of your Z's to also participate in this webinar. To our audience, I want to announce that this webinar is being recorded and will be available also for you to review it again at the end of this or at your convenient time. At the same time, the chat function is available for you to post any queries or questions you might have to our panel of speakers. We will do our best to try and answer the questions, and those that cannot be answered in plenary, we'll try to come back to you with answers post the webinar. With that, I want to go back to Lucy, who explained that she from Hystra. And Lucy has deep experience supporting the scale-up of essential health products. And I want to invite you to reflect on whether it is necessary to have private sector approaches for multiple micronutrient supplementation. And if so, what would be the challenges in doing so? And I know you have a couple of slides, so I will ask our tech team as you start talking to also put up your slides. Over to you, Lucy.
Thanks a lot, Martin. Yes, it's always better to provide some concrete examples. So I want to share some of the learnings we had from working in Pakistan between 2020 for the feasibility study and then from 2022 to 2024 for actual market tests for maternal supplements. Initially, those were focused on balanced energy proteins, so products that basically also have macronutrients, not just the micronutrients that MMS can provide. But why did we do these market tests? The graph in the middle here that shows the number of undernourished pregnant and lactating women in Pakistan is the reason why Gates Foundation, who funded that work, was interested in exploring those approaches. So these graphs represent the wealth quintiles. The WQ1 at the bottom is the lowest, as in poorest wealth quintile, all the way to the premium channels that are at the top. And so this represents the number of undernourished pregnant and lactating women in those segments served by rural and urban areas. Obviously, this is focused on undernourished because balanced energy protein is specifically for undernourished women. But if you translated that to all pregnant and lactating women in terms of proportion, it wouldn't look that different. And so you can see that in urban areas and rural areas, a lot of the women were not really covered either by the government approaches and social safety nets programs that were distributing those products for free, nor by the premium private products that were available on the market. And this reality is true across many markets. Even when you have a broader reach of the public sector, there are still even in developing markets, a significant numbers of women who resort to go to the private sector, especially at a time that is so critical as an antenatal time and need for care. So specifically in Pakistan, there were actually over 60% of women already using the private sector channels, both for purchasing supplements and also for delivering their babies. And they were not covered again by those public sector approaches. So we had two market tests, one in urban areas with a price point that was meant to be potentially profitable for the product, and working with the Green Star as a partner for this approach, working with the local doctors in urban areas. And in rural areas, we worked with RSPN, which is the Rural Support Network of Pakistan, that has local women in nearly every village of Pakistan that can serve as a point of contact for providing information as well as selling products. But before getting into the results of that market test, I want to share on the next slide one of the pieces of the study we did before starting the market test on the challenges faced by women to access antenatal care and in particular purchase supplements. So this little graph at the top represents the woman's journey from when her pregnancy starts all the way to the childbirth in terms of potentially taking supplements. So the first step, the little one on the left, is the moment she learns she's pregnant. Then she typically will go or will not go to the doctor or the healthcare professional. He might or might not prescribe supplements, and then she might or might not buy it, or her family might or might not buy it for her. And then that's still not the end of that journey. There's still the question of whether she will consume frequently. And when we think about MMS, we often think, okay, we just need to get the product to these women. But actually, just getting the product to these women already has a lot of steps. And then even if you do get the product to the women, there's the question of whether she is or not going to consume it frequently. And as you can see with the little red dots at the bottom, there are barriers at each one of these steps. In Pakistan, for example, the first visit, so that's the first barrier below the number one in red, the first visit sometimes happen as late as the third trimester, first visit to the doctor during pregnancy. So obviously at that point, it's already too late to consume multiple micronutrient supplements. Then the HCP, when we started that program, they were not aware either of balanced energy protein nor on MMS that hadn't yet been put on the UNIMAP list. They were prescribing some supplements, but typically not UNIMAP MMS. And they were also making trade-offs in terms of providing a recommendation that they thought would match the ability to pay of their patients. So even if they knew about the best supplements, they might not prescribe it thinking this might not be right in terms of how much my patient can spend. Then the purchase decision, we found that only 30% of women were able to decide by themselves what they would buy after they were prescribed something. 70%, either it was their husband or family that decided for them, or they had to make the decision together. So even once they had the prescription, going to the pharmacy and purchasing was not immediate. And finally, the consumption frequency challenge. What we found is that when you had constant reminders, like in rural areas where the RSPN local ladies could go back to the households and remind them that they needed to buy again, we got to consumption frequency of 10 sachets of balanced energy protein initially, and then pills of MMS per month on average, which is already pretty good, but it's still far from a daily dose, with that question of how can this be encouraged further in a cost-effective way. So I'll stop there. These are the challenges in trying to sell MMS, yet it's still essential, as we saw on the first slide. Over to you, Martin.
Awesome. You have a lot of experience with studying these market-based models. And I agree with you that in most countries, we have a segment of the population that actually accesses their medical products, health products through the private sector. 60% in Pakistan. You mentioned that's quite substantial. I wonder how the numbers are now after the scale up of the activities there while you are there. You mentioned adherence and acceptability of the product as one of the factors, and also women coming early to the to the antenatal care clinic. Now, I wonder, based on your experience and what you saw, studying BEP and MMS in Pakistan, how can we, or how can these market-based approaches help accelerate MMS, scaling MMS in countries sustainably?
So it's a very good question, and again, there are all these barriers to overcome. So I think joint approaches, or at least coordinated approach with the public sector to raise awareness of MMS is the first step. Because if doctors get contradictory information between their work at the hospital or in the public space and their private practice, obviously that would be a challenge. But then there's also a question of making sure that the pricing strategy for these products is right, because, for example, in Pakistan, we were quite astonished, but there were already 2 dozens of pills that were marketed as healthy for pregnant women on the market by the time we started this, and none of them was yet Unimap MMS. And you already had a range of prices from the IFA products that were the cheapest all the way to very premium products marketed by international brands that were literally 10 times more expensive. So I think finding the right price point for Unimap MMS together with the right kind of marketing push and awareness will be key. And finally, one thing that hasn't really been tried, but that we really think could help more generally, is to not just tackle this as MMS, but to tackle this as part of a women healthcare continuum, because there's the same challenge for promoting family planning. There's the same challenge for promoting menstrual health products and providing awareness to women as to what their choices are, basically across their life cycle as reproductive women, as women of reproductive age, as the technical term goes. And if there was a way that all these products could be provided in the same place, that there would be this place trusted place where they could go, whichever their needs are, you could potentially get them much earlier in their pregnancy, for example, if they had like quarterly checks on their reproductive health needs, and they were already coming anyway to purchase their family planning products. The moment they decide to stop family planning could be a great moment to tell them more about what they could do during prenatal times. So I think this more holistic approach would really be a great way forward in terms of ensuring they have access to MMS, but not just MMS, also all these other services they will require during their lifetime.
Wow. I think, and I will come back to you, I'll circle back to you. But one thing that strikes me is I wonder whether has tried to look into if you were to give one metric to governments, one metric that they would prioritize to assess whether their MMS scale up, whether public sector, private sector is on track. What would this metric be? Perhaps you can think about that, and we'll come back to you in the discussion section. For now, I want to go to our second speaker, Lauren Lau. She already introduced herself. Lauren, you have a lot of experience with manufacturing and supply of MMS products, especially in the Philippines. And supply readiness of a country determines whether the country can securely afford to procure or even manufacture quality MMS at scale. As a company that is selling MMS to government and through market-based models, what would you need to further scale? What are the key enablers and constraints that are in front of you as far as scaling is concerned? And also, could you also reflect on why MMS is central to your business strategy as a company? Because what we keep hearing from many manufacturers is that it's really difficult to get a good price point, going back to Lucy's point about pricing strategies. Lauren.
Yeah, thanks, Martin. The key enablers and constraints vary from one area to another. Like what Lucy said in the context of Pakistan, it has something to do with the market-based model. But in the context of Philippines, I think there are two factors that can help scale up MMS. And these are strong policy coherence and a robust supply chain. Let me go to the strong policy coherence. I think the government, the national government, should have an active working guidelines and strict technical specifications on procuring and implementing MMS programs nationwide. Program officers and implementers should have a training on MMS and how it is going to be used from the top to the bottom implementation. Currently in the Philippines, with the influx of MMS donations, program officers administering the tenders are often unaware of the differences between MMS and other prenatal multivitamins. And I think because of that, the Unimap formulation and the product quality are not ensured. Let's talk about the robust supply chain. Right now, there is no local source of MMS in the country. We are importing it from UNICEF-approved facilities. And I think it would be better if the government can somehow incentivize and develop local manufacturing of MMS to ensure there's a stable and flexible supply in the country. To your next question, why is MMS central to our business strategy? Well, Philippine Nutri-Foods is a company that has been operating for almost 5 decades now in both government and market-based models. And because of the nature of our business, we need products with a high social and commercial value to cater to both markets. And MMS is one of those products. It is evidence-based and effective, and the Unimap formulation somehow provides a global legitimacy, which is why I think the government is starting to transition from iron folic to MMS. And it also gives a compelling value proposition to the retail market as well. The doctors that you're talking with, the pharmacies that we are presenting the product as how do you say it? The Unimap formulation is somehow unique to them. It's a unique selling proposition. That's what we're saying. So having this dual strategy allows our company to reach a wider range of populations covered by the government and those outside of public health programs. Thank you, Martin.
I like that. And the ideal scenario would be where you go to a government clinic and you can get the government financed Unimap MMS. And when you go to the private pharmacy, you can also access Unimap MMS at a good cost, right? That's what we all want. But I like that you mentioned the issues of local manufacturing, incentivizing local manufacturing, and making sure that supply of quality Unimap MMS is available. Strong policy backing, which is coherent and understood by all. Robust supply chains. There is also the consensus guidance statement on the specifications of Unimap MMS. And on a side question, I wonder, has this been helpful to you as a company to have free access or freely available consensus guidance on how to manufacture a high quality Unimap MMS product?
I think it's not really a question of the access to it, but it's more of the availability of the resources in our country. Philippines is not known to be a manufacturer of pharmaceuticals. Most, if not all of our pharmaceuticals are imported. I think what I'm trying to tell in the context of manufacturing is that maybe there will be some parts of the manufacturing that we can implement in the country, wherein we can reduce, the cost of MMS rather than importing it at higher cost. So, yeah, I think at that point, but not the entire manufacturing from the source to its finished product, but some parts of it.
Okay, I hear you. And I just to follow up to that before I go to Lady Mary, I wonder, as a company, what kind of procurement commitments or regulatory steps would you think if you got them from the government side, would make the biggest difference in enabling you to make predictable choices when it comes to supplying affordable MMS? Sorry, Lauren, you're muted.
Sorry, Martin, I thought it's for Lady Mary. Can you repeat the question?
Okay, fine. I'll leave that for you to reflect on, and then I'll come back to you. It was a question more about, is a national a Philippine national foods company who intends to supply MMS to the government in the Philippines. Are there procurement commitments that you would like to, at least to hear coming from the government side, or regulatory steps that you think would be really big enabling factors for you to say, yes, we can now comfortably move into MMS provision nationally? Perhaps you can reflect on that, and then we'll come back to you. For now, I would like to move on to our third panelist, Lady Mary. And Mary Dina Foundation has been piloting blended financing approaches to expand access to antenatal supplementation products, including Unimap MMS. Could you, as a start, briefly describe how these financial instruments are structured and how they interact with the procurement of, for example, Unimap MMS? This is mainly for those of us who are new to, like me, who are new to blended financing instruments.
Absolutely, thank you so much. So essentially, blended financing is like a mix of financial options, and it usually would involve a philanthropic anchor capital. So that could be funding from a large philanthropy, for example, a Gates Foundation, and other large philanthropies as well. Usually that aspect of the funding would be given interest-free, or perhaps with certain moratoriums, so you might not have to pay for a certain number of years, even if there is a payback. So it's very favorable terms, and they tend to come in to de-risk the whole model and also to make it very successful from the start on the basis of that partnership. It would also include long-term loans and a portion of debt financing, which you would essentially get maybe from a development bank, for example, the World Bank or African Development Bank. And they also would essentially give concessional rates for the loans, long-term loan opportunities, payback that could be 10 years plus, or 15 or 20 years. And it would also include perhaps other investors and private sector partners who also want to be part of this impact. For us at the Mary Dina Foundation, we've set up an instrument called the Maternal and Newborn Fund. It's a $250 million fund that is designated to support MMS and the scale-up of MMS across 21 countries initially, and then scaling up to 63 countries. It's a blended financial model. We're in partnership with development finance firms to structure the financial properties of the fund. It normally would involve an association, so a charity arm, and then probably an SPV, a special purpose vehicle, that would engage more in the investment side. And then, of course, fund managers will be part of it. Monitoring and evaluation specialists will be part of it. And then we also have a very strong board as well. People who are experts in the field, not only in the field of financing, but of course in the field of humanitarian response. People who have worked with nutritional aspects of the fund, people who have worked with MMS, some producers and manufacturers of MMS, and so on. For us also, the fund that we've created is focused on a campaign called the 100 Million Refugee Mothers Campaign. And the idea is that we have a 20-year goal to support 100 million women in displaced communities and in host refugee communities as well. We've already started quite strong. We've been operating in the northeast of Nigeria, also the far north of Cameroon, the Lac province of Chad. I remember speaking with a president of an international UN agency, and he said to me, "You've managed to be in some of the hardest places to operate in the world." And it's very true. These are very, very tough terrains. But we've always believed that the hardest people to reach are the most important people to reach. And so there are lots of women around the world in refugee camps, in IDP communities, who need these supplements, who are malnutritioned, and their lives and the lives of the newborn is at risk. One of the key things also about this implementation is that for every beneficiary, we essentially multiply by 2, because you're saving the life of both the mother and the newborn. And so that's how far we've come with both the Maternal and Newborn Fund and the 100 Million Refugee Mothers Initiative.
Awesome. I think this is one of the things that we want to hear, people who have figured out how to do it, but are also doing it. But in also the remotest places, which are not the easiest to reach. I worked in Nigeria And I have colleagues from Cameroon, and I know intimately that how difficult it is to operate in some of those terrains that you mentioned. And so I want to, for my own benefit and the benefit of our audience, to ask of, based on your experience delivering these maternal and child health nutrition interventions in these really complex settings, are there key lessons that you have come across that can guide the scale up of a UNIMAP MMS in all these countries that we are targeting, including the ones that you mentioned?
Absolutely. Absolutely. I think coordination and collaboration is one of the biggest lessons. It's an age-long lesson. It transcends beyond philanthropy and business into even personal lives. You know, you can't operate as an island and you can't succeed alone. So we always stand on the shoulder of giants. There have been people that have been doing this for many, many years, for decades, and we work with them. We're also lucky because about 6 years ago, when we started operating in conflict regions, we designed the program with USAID, and we've been funded by USAID. We're also very lucky to be one of the few organizations around the world that has been kept, by the US government. We've been able to, be sustained throughout the changes in administration. And so we've migrated from USAID to the US State Department in terms of funding, and 100% of our budget was kept. I really believe that it's, because of perhaps the scale of and the complexity of the programming that we're doing, and our collaborations are very, very key to the success and the scale up. When it comes to distribution, we work very closely with the public healthcare centers, and very early on, initially, we were distributing from our own health posts and our own distribution centers when we were attending to perhaps 10,000 beneficiaries. As we scaled up to 102,000 beneficiaries that we're attending to per year now, and we're also quickly moving up to 500,000 beneficiaries a year, we realized that there's no other way but to integrate and work very closely with the existing government structures, the PHCs, the antenatal care centers, and work with them, train the healthcare workers, monitor our work together with theirs, and really be able to pull data sources and share those data sources with government. And this has worked for us in Nigeria, Cameroon, and Chad. And as we expand now, currently we're expanding to 5 other countries. We've essentially followed the conflict from the northeast of Nigeria into Cameroon, the neighboring country, into Chad, and now a lot of the refugees from Sudan have come into Chad on the eastern border, and then the conflict in the DRC and Central African Republic. These countries are neighboring each other, and we found that the same lessons help us to succeed in terms of scale, partnering with the government, partnering with established PHCs and health posts, and never trying to reinvent the wheel, always enhancing the structures already in place. One of the other key lessons or successes that we've had is our mother-to-mother groups. And this has really helped us to improve the adherence of the supplements that we distribute, both MMS and also SQLNS, which is small quantity lipid-based nutritional supplements, such as Enough Mom and Enough NutriButter for the pregnant women and also for the babies. So what we do is that in the communities, we set up small groups of about 15 to 20 mothers. It happens in the home of what we call a lead mother. So these are safe spaces where the women feel open and comfortable enough to share. And in those small groups, we're able to disseminate training and information about maternal nutrition, which includes the products that we're distributing, but also exclusive breastfeeding, which is very important, but also sexual and gender-based violence and protection, so that people are able to share their experiences and we can help them to protect themselves in those kind of regions. To date, we've trained over 380,000 women through these small groups of 10 to 15 or 20 women, and this works across all of the areas that we're in. So those are one of the key strengths and success tools that we have in our toolbox.
Thank you very much for sharing those. I'm sure people are taking notes, and I want to come back to the issue of financing and the blended capital, because when countries are thinking about transitioning, financing is always being put at the front as a major bottleneck. Do you see ways that, or could you give tips and tricks of how countries can unlock this, essential financing through these blended financing models?
Yes, absolutely. I think one of the key ways that that countries can do this is by pulling closer both the private sector and the third sector and civil society, so the NGOs, and really coming together to create like a tripart union, that's going to have government entity and philanthropic partners, NGOs, as well as private sector. Just a few days ago, I was speaking at the Houses of Parliament in the UK, and we were discussing exactly the same thing, how the UK government can partner with African governments, including the Nigerian government, and how better they can do that. One of the key things that came out of that was that a lot of governments are moving from donor to partner. So we're in a new era of philanthropy. It's a new day, from the, I think, 19th of January this year. It's a lot of things have changed, and people, because of restricted funding, the funds that are available through governments, we want to make sure that it's sustainable, that it is able to, outlive us, that it's able to stand the test of time and be able to withstand economic downturns. And that was for us, a wake-up call, this year, even though we've continued our partnership with the US government. But we just realized that we don't ever want to be in a position where we would disappoint the beneficiaries or go back to the field or to the refugee camps and say that we have to stop a distribution or an implementation that we've been doing before. We have to stand on our own 2 feet. We're the most passionate about the causes that we've decided to support, and all the other partners are with us, supporting us. But I think that as NGOs and as philanthropists, we have to really take ownership, together with the government, of course, and with the private sector. But I think we're in a very good position to be leading that initiative and those interventions.
Very, very well answered. Thank you so much. And I want to circle back to our other speakers, but before I do that, there's a question in the chat from Vani. In all these settings, was MMS registered as a drug or a supplement? I believe, Lauren, perhaps you can speak on about the Philippines.
Yeah, for the Philippines, it is registered as a drug now. It has transitioned just this year from food supplement to drug.
And Lucy, do you recall in Pakistan whether it's registered as a drug or a or a supplement?
So at the time, it wasn't decided yet, and we had done a study. I've shared it in the organizers group. I don't know if I can share it on the chat, but if people are interested. So at the time, both routes were being envisioned with different consequences on the timeline to register any new product that would come on the market. Again, at the time, there was no Unimap MMS. There were like micronutrient supplements, but not Unimap MMS formulation on the market in Pakistan.
Okay, and I can share the experience of other countries and give the example of Ethiopia, for instance, where there has been a major discussion about registering as a supplement or as a drug. The main issue usually is about how the government sees the two. In some countries, when you register as a drug, you get their tax advantages, so that the product can be sold at lower cost. But when you register as a supplement, it's much more expensive. So then it's way, compared to iron and folic acid, the issue of cost parity becomes a challenge. So this question shifts depending on the country that is under discussion. Now, we are coming to the end of our webinar, and before we do that, I want to invite our panelists to reflect on 2026, because we're in December and 2026 is coming in very, very soon. Lady Mary mentioned that we are in a new era of financing, a new era of doing things. We want high quality MMS for our women, but we have to pay for them one way or the other. So looking ahead in 2026, what one action is most needed to accelerate MMS scale up in the countries you know about, but also largely in the LMICs? And I will go back to Lucy and remind her also of my other question about a metric that the government can use to monitor progress. Lucy, back to you.
Yeah, I'll answer the last one, and I leave my colleagues to answer the new question. So on the indicator for MMS, I mean, ideally, the indicator you would want to follow is the number or percentage of pregnant women who take MMS regularly enough for impact. So ideally daily, and obviously that's quite tricky to measure. A proxy to that could be the number of women who restock MMS if it's not given in 180 bottle, which by the way is not the preferred format for women. They do tend to prefer smaller format that they can carry with them, like a blister, and that's even more true. Like if they actually have to pay for it, they don't want to buy a 180 bottle. They much prefer a blister format, even if it's more expensive per pill. Basically, if that was the case, that would have the benefit from a monitoring perspective, that you could ideally check how much women repurchase the product or restock the product from public health centers, to be able to get that proxy of whether they're actually consuming it regularly or not.
Thank you, Lucy. I have to add here that we hear mixed responses to the 180 versus the 100 versus the 90 versus the blister pack of 30. The evidence coming from Ethiopia, for instance, and we have published a recent paper on acceptability and adherence of MMS. There is now evidence to show that other countries, women also prefer the bottle of 180. And that does not seem to actually impact their decision to return for the subsequent visits. They actually like, and it makes logical sense to me. Even in high-income countries, a pregnant woman gets her medical interventions irrespective of the fact, she knows how to keep her appointments, and so she just feels nicely treated as a human being by herself. So yeah, so we have to also keep evaluating the evidence. I will go back now to Lauren and ask you to reflect on the question I asked about 2026. Is there one action from where you sit that you think is needed to accelerate MMS scale-up?
I think there is no one solution for this problem. I guess it will be a specialized one, a localized one. You have to know first where we are operating, and then from there, maybe we can identify the strengths and the opportunities we can use. And then maybe, okay, I don't know, like what Lady Mary said, we can also ask the help of private and public partnerships that can, somehow help the scaling up of this MMS. So that's my take.
Thank you, Lady Mary.
Yes. Yeah, I was looking at the poll that we started the call with, and I saw that financing was, it had the highest percentage in terms of the barriers to expanding MMS, and I think it's very true. So for me, the one key thing is really unlocking financing opportunities for organizations that are making impact. I remember earlier this year there was the Financing for Development conference in Sevilla in Spain, and a lot of the key philanthropies were present, and there were pacts and agreements made that there would be more funding for humanitarian causes. I think all of us should knock on the doors of those development financing firms, whether it's World Bank, IFC, African Development Bank, British International Investment. Every single opportunity where there is funding for philanthropic and humanitarian causes or impact causes, I think we should access it, knock on those doors, be able to really put our cases forward and raise that finance. Because if we don't do it, the private sector keeps doing it, but then they do it for profit. We are doing it for impact. We're doing it to change lives. And it's time for us to have our own financial resources to be able to do so.
I fully support that. And just reading some of the messages that we are getting in the chat, in Pakistan, Indonesia, and Bangladesh, different surveys have found that blister pack were the preferred format by a large margin, but it might depend on the local context and preferences. So that's a contribution to the what Lucy also found. We have some questions that have come in the chat. Perhaps this one is for you, Lauren. Would market shaping, or rather, Lucy, perhaps, would market shaping differ when registered as a drug versus as a supplement?
That is a question that would probably require a country-by-country analysis. But in Pakistan, it had a big impact on what you could or couldn't do in terms of marketing. and whether you absolutely had to go through HCP or were able to also do direct to consumer or even advertising out in the street. So, but again, I think it would really depend on on the local context and what is tied to both status in different countries.
Makes sense. And I would also add that there's some questions that have come to the chat asking for whether it's possible to reach to our panelists post the webinar. That can be arranged. I think you will, via the email which you registered with, when you get the recording, you can always respond, and you'll be able to be linked with the panelist who you wish to talk to. Now, we are coming to the end of our webinar, and I want to close by emphasizing the core messages that came out of today's webinar. And I think I learned a lot personally, because the topics, manufacturing, blended financing models, those are not my usual topics in a typical workday. We started by hearing that MMS offers clear added benefits over IFA. That's what stakeholders have found, especially many of the stakeholders who are part of the Healthy Mothers, Healthy Babies Consortium. We now have over 450 individual members and over 60 organizations that are part of the consortium. And everybody keeps reporting on the safety and cost effectiveness of MMS in high burden contexts. We have heard that policy alignment, financing, supply chains, and governance must be coordinated for successful national transition. If that does not happen, then it's not very, or rather the transition pathway is going to be longer. If we have better coordination, we can get there faster. Market shaping, demand generation, and local manufacturing can reduce the barriers. And we had that from Lauren. It was emphasized also by Lucy, and Lady Mary also made it clear that where you have strong stewardship at, whether at a philanthropic level, but also at government level, then you get progress. Blended financing can help de-risk early adoption of MMS, but sustainability seems to depend on domestic systems and budgets. So we have to leverage blended financing, and I hope we all learned, as I did from Lady Mary, to unlock domestic systems, so that then we can in future sustainably fund our scale-up activities. Hopefully have UNIMAP MMS procured and supplied using local government financing. Now, there are early steps that are, countries can take, such as feasibility assessments, thinking about registration, regulation, pilot procurement. These are immediately actionable steps that countries that are considering introduction of MMS can take. But this will require public, private, philanthropic world, implementing agencies. I think I cannot put it as good as Lady Mary did. We need everybody around the table to discuss how to introduce a high quality health product for our pregnant mothers, and then see how to scale it up sustainably. With that, I want to thank our panelists for the really insightful discussions today. And I hope that if any questions that have come to the chat are sent your way, you will help us answer them. And thank you very much for making time and for your presentations today. I also want to thank our audience for making time to join the webinar today. Until the next time, thank you so much. And the recording will be distributed through the email chain that channel that you got it. Thank you very much, everyone. Bye-bye.
Thank you for the moderation.
Thank
you so much.